It is now my great pleasure to introduce the presenters for today's plenary session. First, we're going to hear from Dr. Reghan Foley, who is a neuromuscular specialist and senior research physician at the Neuromuscular and Neurogenetic Disorders of Childhood Section, NINDS, at the National Institutes of Health. Dr. Reghan Foley will talk about COVID-19 and how it impacts the neuromuscular community. Take it away, Dr. Foley.
Thank you, Rachel. I'm going to try to be as comprehensive, but more important, comprehensible, in covering a topic which is very important to all of us, and that is the topic of keeping our congenital muscle disease community safe and also thriving during the COVID-19 pandemic. We were all very fortunate to be able to gather together as a large congenital muscle disease family at our first Cure CMD Scientific and Family Conference back in 2017. At that point in time was our largest gathering to date of 487 individuals. And thankfully, we could gather together safely with no need for social distancing. And then in 2019, we were able to gather again at our second Scientific and Family Conference, and a wonderful opportunity to bond. And again, there was no need for social distancing. And since that point in time, we have been together, but not in person, but rather in spirit. Then in late 2019, COVID-19 was detected first to infect humans. So COVID-19 goes by a few names, also known as SARS-CoV-2 or Severe Acute Respiratory Syndrome Coronavirus 2. It spreads from person to person via droplets released when a person with COVID-19 coughs or sneezes or talks or sings. Much less commonly, it can be spread by touching an infected surface and then touching one's mouth, one's nose, or one's eyes. Again, that's a much less common form of transmission. The World Health Organization came out with information on the known means of transmission as being that of patients or individuals being infected, being most infectious just before they develop symptoms, so namely 2 days before they develop symptoms and early on in their illness. People who develop severe disease may be infectious for a longer period of time, however. While someone who never develops symptoms can pass the COVID-19 virus on to others, it is still, at this point in time, not entirely clear how frequently this occurs. It's felt to be an infrequent occurrence, but again, it's still possible. The COVID-19 Prevention Network was established very early on in the pandemic, and it was formed by the National Institute of Allergy and Infectious Diseases here at the NIH to respond to the pandemic, and using an already established extensive network of infectious disease partners. So because of the already established network, the COVID-19 Prevention Network was able to get quickly at work working towards vaccines and potential treatments. And I wanted to list for you here a wonderful resource that the Coronavirus Prevention Network has available online. And just to note that all of my slides from this talk will be available online for reference. So many people have asked, how is it possible that the COVID-19 vaccines were developed so quickly? How could they possibly be safe and effective? And the reason is, from the very beginning of the coronavirus pandemic, the COVID-19 Prevention Network was able to see that there was extraordinarily important need for the development of vaccines on a very short timeline. So rather than pursue the typical approach of sequential phase 1, phase 2, and phase 3 trials, the clinical trials began, and as the phase 1 trial was still in progress, phase 2 began, and then phase 3 began while phase 2 was still in progress. And during the clinical trials, manufacturing on a large scale was already in progress based on the hope that the vaccines would be proven to be safe and effective. So even before licensing, even before approval, manufacturing was already in process. So that explains how the timeline was shorter. There were no corners that were cut. And most importantly, safety has been always the focus of all the clinical trials. So we can say at this point in time that we have a large abundance of data on safety of the different COVID-19 vaccines. An important also concept to think about is that any acute response or any adverse response from a vaccine happens on the order of hours or days, but not months or years later. So we do have the ability to have now a lot of cumulative data on the vaccines that have been now in use for quite some time. So the different types of vaccines that you've been hearing about in the news, probably most commonly you hear about the mRNA-based vaccines. This is a new vaccine that was based on research at the NIH. And in contrast to prior vaccines, these vaccines are based off of protein. So the mRNA for the COVID-19 vaccine is based off the spike protein of the virus. There are two different mRNA vaccines, one made by Moderna and a second made by Pfizer, BioNTech. The most recent study coming out on the mRNA vaccines in the largest cohort came out about a week and a half ago. That was in 500,000 healthcare workers that demonstrated 94% efficacy in prevention of symptomatic illness after 2 doses and 82% efficacy in prevention of symptomatic illness after 1 dose. And the period of time between the 2 doses for the Moderna vaccine is 4 weeks, and for the Pfizer vaccine is 3 weeks. Now, that's the recommended time period. If the time period is a bit longer, it would still be effective, but the recommended time period is 4 weeks for the Moderna vaccine and 3 for the Pfizer vaccine. And just kind of show here in the schematic that lipid nanoparticles is the means by which the mRNA is delivered into the cells. So the mRNA enters through the injection, and so into an intramuscular injection. And some of you have asked, what if my muscles are small or atrophic? Will I still get the vaccine? Yes. Doesn't matter the size of the muscle, the vaccine will be injected into the muscle and relies on a localized immune response as nanoparticles deliver the mRNA into the cell and gives the cell instructions to make a spike protein. That happens within the first 24 hours of vaccination. The cells make the spike protein, and that stays on the surface of the cells for about 3 days duration. Then the body's immune system will see that spike protein as foreign, as an invader. And so then there'll be a full-blown immune response. So the next time the body may be exposed to the coronavirus, the body will know it is foreign and will mount an immune response. So there are also another subtype of vaccines known as adenovirus vaccines. One of the adenovirus vaccines is made by Johnson & Johnson Janssen Company, and that's administered as a single dose, and it has shown efficacy of 72% in the US, lower efficacy in countries with more contagious variants. The other adenovirus vaccine is made by the team at Oxford in combination with AstraZeneca, and that uses a chimp adenovirus vector, and that is administered in 2 separate doses, which are recommended to be given 12 weeks apart. And the efficacy is 78.9% in the US and South America, and 62.1% in the UK and Brazil. I just lost my slides. Good. Okay. So some of you asked a question about the adenovirus vaccine and eligibility for future gene therapy trials. So some news articles have incorrectly abbreviated the adenovirus vaccines as AAV, and that's incorrect. None of the currently available COVID-19 vaccines use an adeno-associated virus or an AAV, and thus none of these vaccines result in producing antibodies against AAVs. If in the future such AAV-based vaccines become available, then their use may be contraindicated for those individuals who would be candidates for AAV-based gene therapy in the future. But it's very important to know that the adenovirus vaccines are not containing adeno-associated virus, which is used in gene therapy studies. In terms of vaccine approvals, I'm trying to kind of summarize here the approvals both by the FDA and the European Medicines Association. So the FDA has approved the mRNA vaccine by Pfizer under emergency use authorization down to age 12 years. And in the EU, it's been given conditional marketing authorization down to age 16 years. The mRNA vaccine from Moderna is approved in the US down to age 18 years and approved in the EU also down to age 18 years. The adenovirus vaccine has been given FDA emergency use authorization down to age 18 years, and as well in the EU down to age 18 years. Some of you have asked about children less than 12 years of age, what are options? There is a clinical trial of the mRNA vaccine by Pfizer for children between the ages of 6 months and 12 years. It's a placebo-controlled trial, meaning that it's not guaranteed your child will be given the vaccine, the mRNA vaccine. It is active in recruiting. I've included here the clinical trials identification number for more information, and it's testing the vaccine actually at 3 different doses, a low, a medium, and a high dose. And what are common observed side effects from the mRNA vaccine? So most commonly, there's going to be pain and redness and swelling on the arm where you receive the vaccination. And then also there can be other systemic side effects such as tiredness, headache, muscle pain, chills, fever, and nausea. Most commonly, the side effects happen within 7 days of vaccination and last between 1 to 3 days duration. And most people report more side effects after the second dose of the mRNA vaccine. With the adenovirus vaccine, the Johnson & Johnson and AstraZeneca vaccines, beyond the typical vaccine side effects, there has also been a side effect which is called thrombosis with thrombocytopenia syndrome, which indicates that there's formation of blood clots in vessels and low platelets, as well as in particular, some patients who developed a cerebral venous sinus thrombosis. These side effects are rare, and they have been more common in females who are younger than age 50 years. However, these side effects have also been seen in some males. So both Johnson & Johnson adenovirus vaccine and the AstraZeneca vaccine have been evaluated in great detail, and the FDA has stated that the benefits of the Johnson & Johnson adenovirus vaccine outweigh the known risk. However, if you're in the risk category of being a female younger than 50 years of age, it's important to know that there are other vaccines that are available that do not carry the risk of blood clots and low platelets. And very similarly, the same type of statement was made by the EMA for the AstraZeneca vaccine, that the benefits outweigh the risks. Some of you have asked about vaccine doses and why is it the same doses given to an adult or a child aged 12 years. So unlike medicines that circulate through the body, vaccines are used to elicit an immune response at or near the injection site. And so the clinical trials of these vaccines are assessing the immune response and the adequacy of that immune response and what dose is necessary to achieve that immune response. And the immune system is different for a child than for an adult, but down to age 12 years, it was seen that the same dose for the Pfizer vaccine of 30 micrograms was safe and effective in children to age 12 years as in adults. Currently, the trial from age 6 months, 12 years of age for the Pfizer vaccine is studying 3 different doses. For the other vaccine, the Moderna vaccine, Johnson & Johnson, and the AstraZeneca vaccine, for the approved age range, it is all the same dose. The American Academy of Pediatrics came out last week once the approval of the Pfizer mRNA vaccine was approved down to age 12 years. And they came out with a statement to recommend that COVID-19 vaccination be a recommendation as the Academy of Pediatrics for all children, adolescents 12 years of age and older who do not have contraindications to the vaccine, and that also if any other further COVID-19 vaccines are authorized by the FDA for emergency use authorization, they would be recommended as well. What does fully vaccinated mean? Fully vaccinated means that 2 weeks after the second dose of the mRNA vaccines, that you're fully vaccinated with full immunity. And also this would mean 2 weeks after a single dose vaccine, such as the Johnson & Johnson Janssen vaccine. It's very important to remember that until you are fully vaccinated, it's important to keep taking all precautions. What are those precautions? Well, one of them is mask wearing, which we've been talking about for the past year. And the guidance on mask wearing has become more complex over time and more complicated. The most recent guidance has come out on May 13th from the U.S. Center for Disease Control and indicates that those individuals who are fully vaccinated, if they wish, can remove their mask because they are at low risk for COVID-19 severe infection. And those that are not fully vaccinated should still be wearing a mask in most situations, except when with family members of their own household or in a small outdoor gathering with fully vaccinated family and friends. It's very important to know that this new guidance does not mean, according to Dr. Fauci, very important, that does not mean people who feel they want to continue to wear masks should not wear a mask. It's not a mandate to take your mask off. For those who are fully vaccinated and wish to remove their masks, you do not need to wear a mask indoors or outdoors, except while in any form of public transportation or visiting prisons, jails, or homeless shelters. And also there are going to be state and local laws and certain rules and regulations, obviously in schools and businesses and workplaces. And very importantly, hospitals and outpatient medical offices and nursing homes continue to have mask requirements. For those of our patient community who have a tracheostomy site, that should also be covered if you're unvaccinated, and again, you're visiting a location like a medical center or on public transportation. And a way to prevent droplet exposure would be to wear a scarf or a bandana that has at least 2 layers of fabric, or a surgical mask to cover the tracheostomy site. A speaking valve, such as a Passemer valve or a humidified moisture exchange, is not considered adequate coverage. Vitamin D, we know as a community, is very important for bone health. And so we should be taking vitamin D daily. The recommended dosing for children is between 600 to 1,000 international units a day, and for adults between 1,000 to 2,000 international units a day. It's also important to recognize that vitamin D plays an important role for immune function. It enhances our immune system, our innate immune system, and prevents overactivity of the immune system, which can be dangerous when the immune system becomes overactive. So do not forget to take your vitamin D, both for your bones as well as for your immune system. And there have been a few studies that have kind of suggested that those individuals who were more ill with COVID-19 infection requiring ICU care tended to have vitamin D deficiency. So do not overdose vitamin D, but make sure you're taking the recommended dose of vitamin D daily. In terms of what medical appointments, testing, and potential surgeries should not be delayed at this point, at the end of May of 2021, it seems much clearer that things are safer to proceed. I've been part of the World Muscle Society's COVID-19 group, and we've come out with a position and advice that we hope that centers around the world could aspire to, and that is that neuromuscular services should ensure that the hospital is making adequate provisions for safety of people with neuromuscular disorders. So that you don't feel that attending your medical visits would put you at risk. And in particular, pulmonary function testing should not be delayed. Many pulmonary function labs are going to require a COVID-19 negative status prior to you doing your pulmonary function testing. Likewise, polysomnogram should not be delayed, especially if the polysomnogram is planned for the initiation of non-invasive ventilation, such as BiPAP. Also, echocardiogram and EKG and potentially Holter monitoring should not be delayed. In particular, cardiac monitoring should be prioritized for those patients with cardiac involvement. And finally, surgeries have often been delayed during this past year because of the pandemic, but it's important to highlight that scoliosis surgery should not be delayed. If it's indicated because of the degree of the curvature and indicated because of the progressiveness of the curvature, the surgery should not be delayed. Fortunately, with the approval of many of the vaccines down to younger ages, many of our patients that will be undergoing scoliosis surgery may be actually vaccinated prior to their scoliosis surgery. Returning to school is another important topic that has come up, and it's obviously changed over the course of the year. Some schools continue to offer a virtual option, and the decision whether to return to the classroom or to remain at home and do virtual learning is really based on individual factors, including the individual's clinical status and precautions taken by the school to ensure a safe environment. Most schools understand that, there should still be an attempt towards social distancing of at least 3 feet between children in elementary school and 3 to 6 feet between children in middle school or high school. Obviously, it is incredibly challenging to enforce this in young children who naturally want to play together and be side by side. And so it's something that can be enforced probably more easily in the classroom, but again, hard to enforce full time. If the child's outside, there is going to be less of a risk for transmission. Mask guidance may vary the rules between schools. In schools that continue to have mask rules, which most schools definitely do, there should be an allowance for mask breaks to give the child a chance outdoors to take the mask off and take a couple deep breaths. Some of you have asked, is it safe to keep a mask on if my child is using BiPAP at nighttime? The data in general shows that the benefit of wearing the mask far outweighs the risk to ventilation. And if schools remove over time their mask rules, it's important for individuals with congenital muscle disease to recognize that they should be considered more vulnerable or really at high risk for complications from infection with COVID-19. So you may, even in the absence of a mask rule at your school, opt to, and rightly so, opt to continue to wear your mask. The most recent CDC guidance on this as of May 15th indicates that if the schools are strictly implementing the prevention strategies, it seems to be safe to return to in-person instruction. But again, that's an individualized personal decision based on the individual's clinical status and the situation at the local school. And then finally, hopefully this will not happen, but in the event of a positive COVID-19 test. There are a couple options that are available to help decrease length of infection and severity. So one of them is monoclonal antibodies, which has been approved in the US under emergency authorization, and also some of them have been approved as well in the EU. Monoclonal antibodies bind to the spike protein, preventing the virus from attaching to human cells and tag it for destruction. I'll go into some more details about that in the next slide. And there's also remdesivir, which is a medication which acts by blocking the replication of the virus, by blocking really RNA polymerase. And it has been found to shorten the time to recovery in adults and children greater than 12 years of age who are hospitalized with COVID-19. The monoclonal antibodies, there's two different combinations, and they're given together as a combination as a single intravenous infusion. Both of the combinations of monoclonal antibodies that are available are for mild to moderate COVID-19 in adults and children 12 years of age or older who test positive for COVID-19 and are at high risk of progressing to severe COVID-19, but who are not hospitalized and do not require oxygen and who weigh at least 40 kilograms. And this has been given to a few of our patients in the community who tested positive before they had severe symptoms, and they recovered exceedingly well. So important to know that you should be eligible for this if you test positive for COVID-19. And then finally, we had a question from one patient about ivermectin. Their local doctor had said, try ivermectin. It's not recommended. It's still under investigation, so it's not recommended to be taken either to prevent or treat COVID-19. So the pandemic has highlighted our ability as a community of congenital muscle disease community to stay connected virtually, and the importance of this connection for all of us. And I think the children have shown us how resilient they are during this time, even when we cannot be together and hug in person. They've thought about very creative ways to share a hug virtually. And I think together as a community, we can be more resilient and more resourceful when we are connected and we stay connected. I've also been very impressed how via CureCMD you have shared your knowledge during the pandemic, but in particular, I want to give an acknowledgement to Nikki Mead and Luke Hoban for blogging about the pandemic, and for Kiara Sunris talking about pandemic academics, and a nice shout out to Sophie Kim and Kiara Sunris for actually launching an entire pulmonary guide web series during the pandemic with neuromuscular and pulmonary experts. Really bravo for continuing to share knowledge during the pandemic. And then also a shout out to the Lama 2 community in Spain, the Impulsate community, who did a beautiful, if you haven't seen it, not to be missed, a beautiful video that everything will be okay, toda irá bien, and thanking the medical community for their support during the pandemic. We're looking forward to coming together for our next CureCMD Scientific and Family Conference next July. And until then, as a CureCMD community, I hope that we all continue to stay connected, share knowledge, and be there for each other. Thank you.